Hello, I am Dr. Nipun Gupta. I was associate professor in Department of Medicine, MLU Medical College, Jhansi. Today's case is about the high baseline HbA1c in a middle-aged patient with short duration diabetes. Diabetes is a heterogeneous group of metabolic disorders characterized by chronic hyperglycemia. Chronic hyperglycemia lead to microvascular complications like diabetic retinopathy, nephropathy, neuropathy, and erectile dysfunction, or macrovascular complications like cerebrovascular disease, cardiovascular disease, or peripheral vascular disease, leading to atherosclerosis, myocardial infarction, stroke, or gangrene. In US, diabetes is the leading cause of ESRD, adult blindness, and non-traumatic lower limb amputations because of gangrene. Chronic hyperglycemia in diabetics lead to not only significant morbidity, but it also leads to mortality. Risk of mortality increased by about 1.5 to 2.5 times higher in diabetic populations in comparison to the non-diabetic population. More and more adult persons, especially of the middle age, they report to clinics for other symptoms and they are found to have diabetes. Some of them have hypertension, cardiovascular disease, obesity, and dyslipidemia. These persons should be the target for early and rapid control of blood sugar levels to prevent them from having microvascular as well as macrovascular complications of chronic hyperglycemia. But what the studies have shown that there is some clinical inertia on part of the clinicians which delay the proper control of blood sugar levels for early 2 to 3 years. This is mainly due to the clinicians' fear of risk of hypoglycemia as well as weight gain due to the drugs. This prevents significant number of the patients to achieve proper blood sugar level, leading to complications. Early and rapid glycemic control in diabetic patients can lead to better outcome, especially in terms of reduction of micro and macrovascular complications. ADA 2020 guidelines for treatment control. ADA recommended that the treatment should involve control of glycemia and severe risk factors, and there should be patient-centric approach to the care. The pharmacologic agent should take care of comorbidities, risk of hypoglycemia, weight gain, and potential for side effects. Now coming to the case, Mrs. Kamal is a college professor. She is 54-year-old female with type 2 diabetes for 4 years. During routine checkup, she complained of generalized weakness. She was hospitalized for acute coronary syndrome 1 year back and went through PTCA. Her family history is positive. Her father underwent CAPG 5 years back. Clinical parameters: BMI 29.7, body weight 71 kg, BP 146 by 86 millimeter Hg. Lab findings: HbA1c is high, 8.4%, LDL cholesterol 75 milligram per deciliter, HDL 37, serum triglycerides 156, and total cholesterol 168 milligram per deciliter. eGFR 65 ml per minute per 1.73 meter square. Stage 2 renal impairment. UACR is 300 milligram per gram, and 2D echo revealed mildly dilated LA and RV. Her medications: metformin 1 milligram twice daily, glimepiride 40 milligram daily, losartan 50 milligram daily, atorvastatin 40 milligram daily, amlodipine 5 milligram daily, chlorthalidone 15 milligram, metoprolol XR 50 milligram daily, aspirin 75 milligram. She leads a sedentary lifestyle and she tried to reduce weight by exercising few times a week. Her important challenges in the treatment of these patients are uncontrolled hyperglycemia, obesity, hypertension, history of previous acute coronary syndrome, and microalbuminuria. Now, what is the risk status of this patient? She is having a very high risk because she is diabetic with multi-target organ involvement with prior acute vascular event in the form of acute coronary syndrome. What are the ADA recommendation in high-risk type 2 diabetic patients? The ADA recommends that the decision to treat with a SGLT2 inhibitor or a GLP-1 RA to reduce MACE, HH, hypertensive heart failure, CV death, or CKD progression should be considered independent of the baseline HbA1c levels or individualized HbA1c target. That is, these high-risk patients should be treated with SGLT2 inhibitors or GLP-1 RA. Now, what about SGLT2 inhibitors like empagliflozin? These are novel class of oral glucose lowering agents which act by inhibiting sodium glucose cotransporter 2 in the proximal convoluted tubule. This increases the urinary glucose excretion. This action of glucose excretion is independent of insulin secretion or action. Therefore, SGLT2 can be introduced at any stage of the disease process. SGLT2 have potential benefit beyond glycemic control because of their pleiotropic effects. They cause osmotic diuresis and natriuresis, which leads to reduction in blood pressure, decreased arterial wall stiffness, weight reduction, as well as SGLT2 promote reverse cardiac remodeling. As shown in the EMPA Heart CardioLink 6 study, this study demonstrated that empagliflozin can lead to early reverse cardiac remodeling in type 2 diabetics and stable coronary artery disease. EMPA-RAG study in 2015 demonstrated significant benefit of empagliflozin in reducing the heart failure by 35%. SGLT2 also slow the progression of kidney disease. In a sub-analysis of EMPA-RAG study, empagliflozin declined new onset or worsening of nephropathy by 39% on top of the RAS blockers therapy. Addition of empagliflozin was associated with slow progression of kidney disease. The CV and renal benefits seem to maintain even independent of their eGFR levels. Even with the progressive eGFR, this beneficial effects of empagliflozin were found in these kidney patients. Now, what about DPP4 inhibitors like linagliptin? They have a hepatobiliary route of elimination and no dose adjustment is required in CKD patients. DPP4 inhibitors exert glucose lowering effect by increasing the incretin hormones. These hormones increase glucose-dependent insulin secretion and suppress the glucagon secretion. Carmelina and Carolina trials, they established the CV safety of linagliptin, and Carmelina trials also showed that reduction in progressive albuminuria occurs with the use of linagliptin by almost 14%. So, combination of SGLT2 and DPP4 inhibitors like EMPA plus lina should be preferred because both have different mechanisms of action. Addition of DPP4 to SGLT2 inhibitors have found to reduce risk of genital infections due to SGLT2. Combination give early and better glycemic control and help in achieving target HbA1c of less than 7. Combination of EMPA plus lina 25/5 found to lower HbA1c by 1.8% in metformin treated group, having baseline HbA1c of more than 8.5% in the same group. As well as this combination also reduces the pill burden as well as the pocket burden of the patients. Thank you.